love to welcome all of you this morning coming to our meeting on this very dreary day, particularly those that have driven the distance. My name is John Fresh. I'm a physician and I chair the Louisiana Healthcare Commission for the Department of Insurance. I'd like to welcome all of you today and to say that the Louisiana Healthcare Commission was designated by the legislative body and the Department of Insurance for us to look at healthcare issues concerning quality, cost, and access, and to report back to the legislative body. The commission is comprised of a number of different constituency groups, particularly payers, providers, and consumers. If there are any members of the commission who are with us this morning, we'd like you to stand and be recognized, as well as members of the legislative body or their staff. Please, if you're on the commission, stand up and be recognized. She has a number of recognitions and has chaired boards, honors, and president of the National Health Lawyers Association. And at this moment, I'm just going to mention a couple of her activities. She is a chair of the Louisiana Women's International Forum, also is on the board of Baton Rouge Area Foundation, the incoming chair of Women's Hospital, and on the American Hospital Association's Board of Governance. We've been married for 44 years. We have 2 doctor children and their doctor spouses, and 4 grandchildren, of which the youngest is now 4 days old. So, just welcome, Donna.
I think that last accolade is really well deserved. I'm so excited about my 4th grandson. Can't seem to get daughters in this family anymore. But in any event, thank you so much, John. That was a very sweet introduction, even though you're married to me and know me better than any of you. Most of you in the audience have been here before, I think. Why don't you raise your hand if you have? Oh, wow. So you're an alumni association of this meeting, which, by the way, is in, I think, our 26th year, although they haven't been all contiguous years. So it's very, very special that we have this meeting year after year. Look forward to seeing each other, sharing ideas, asking good questions, and more particularly getting your CE credit for being here. I have a number of little housekeeping details other than trying to keep this thing on time, as it were, and one is that the monitors on either side will be the key to your success in being here today because, as you know, we put up some words, and you need to know the magic word. And the first word will be given to you right after the 9:50 or so when we have our break at that point. So look for that word. You need to get all the words in order to get your CE. That's so that we can tell that you're here. Those are your key words. And then you sign the back of your badge. And then it'll be deposited in one of the receptacles when you leave the conference. If you have any questions about all that, the Louisiana Department of Insurance staff is very helpful, and they'll be around to assist you. Also, you'll recall that we have one of the best lunches for any conference that I ever go to, but in order to get the lunch, you have to leave here and clear the room. So, and that's so they can reset the tables. So place the program and notes on your chair, and then wait for the announcement to come back in. And visit our exhibitors. We're so pleased to have them. Without them, we can't do what we do as a conference, and so we greatly appreciate them. I would like at this time to introduce a man who probably needs no introduction to you because I guess at some point, and I don't know if we're there yet, Jim Donlin will be the longest serving commissioner of insurance in the state of Louisiana and perhaps will be reelected and will be the longest serving insurance commissioner. Commissioner Donlin was first appointed in 2006, and then he filled an unexpired term and reelected to 3 consecutive terms. He served as president of the National Association of Insurance Commissioners in 2013, and now serves as the chairman of the Surplus Lines Task Force and is on the executive committee of the NAIC. Before he was the insurance commissioner, Jim served in several leadership positions, including chief deputy commissioner and executive counsel. He served the state of Louisiana for many decades, first elected to public office in 1975 as the chairman of the Jefferson Parish Council. He served as the Louisiana House in the House of Representatives from Jefferson Parish from 1981 to 2001, where he was the chairman of the Committee on Insurance. and 33 years in the Louisiana Army National Guard, where he retired with the rank of colonel. He is a New Orleans native. He graduated from the same school that my husband graduated from, Jesuit High School, and then the University of New Orleans and Loyola School of Law, where I also graduated. Jim and Marilyn reside in Jefferson Parish, and they've got 4 daughters and 8 great-grandchildren. 8 grandchildren, I'm so sorry. Not yet, right. But in fact, our grandchildren are good friends. 2 of them grew up together in Alexandria, and I know they've gone on to just brilliant high school careers at this point. But without further ado, I think one of Louisiana's most important public servants and important leaders, Jim Donlin.
Dr. Bond is a renowned leader in the field of interventional regenerative orthopedic medicine, or IROM, a phrase which he coined. He was a program director at the First World Congress of Interventional Regenerative Orthopedic Medicine in New Orleans in 2015. He is the first physician in Louisiana to ultrasound-guided platelet-rich plasma injections and bone marrow-derived stem cell treatments under ultrasound guidance in 2012. He serves as the president of the American Association of Orthopedics and an authority on regenerative medicine. Dr. Bond?
Thank you for that introduction, Dr. Fresh. I appreciate it. I want to say thank you for everyone for coming and also for having me. I'm really excited to be here and talk about a topic that I'm very passionate about. Just some goals today. I want to review the current state of how things happen, I'm sure most of you are aware of, but also outline some difficulties in the process and then introduce the concept of IROM, or interventional orthopedic medicine. And by the end of this session, you guys should understand those concepts. So I'd like to start with just a case, because you guys are all in the insurance world and you should understand how patients flow through the system and then some of the issues with it. So most of you are familiar with low back pain, and you've heard of patients having low back pain and having issues on the job and even outside the job. So typically the way that things flow clinically through the system is you'll have a patient or a worker that becomes injured, has an issue, is seen either by the company doctor or they maybe go to their primary care doctor, and they start what's called the conservative process or a conservative treatment plan. Once that patient goes through that plan, and that may include physical therapy and maybe anti-inflammatories and maybe some chiropractic care or exercise programs, but once they're through that process and they're still having difficulties, they end up going to, at this point in the process, pretty much one alternative, and that's surgery. And all of you have heard of this, that someone had a slip and fall, they hurt their back, they went through it, went through the conservative process, it didn't really work, they still had issues, so they end up in surgery. And that's a real problem. And this is not Tommy Bond's opinion, it comes from your data that I have pulled and put into this presentation, as we will see. So what I'm trying to introduce today is that there's another option. Not for every patient, but for some patients there is another option, and it's called interventional orthopedics. And I will introduce that here in just a second. So keep this guy in mind. That's case one. And so what are some of the issues or some of the problems within the current state of patient flow or the injured worker, whether you're talking about a self-insured company or through the workers' comp process? One is that it's incredibly expensive. In Louisiana, we certainly know that, as the data would show, that Louisiana has actually the highest indemnity costs in all the other southern states for a few reasons, which I don't really need to get into. It's not real clinical for me, but you guys are much more learned on those points than I am. But we know it costs a lot of money to have surgery. We also know that having surgery puts a bind on the company as well as the worker. So when someone has surgery, they're not back to work the next day, or maybe not the next week, or maybe not even the next month. We know that major orthopedic surgery has a healing time, and that time can vary tremendously. So there is a delayed return to work with surgery. Also, everyone is aware of the problem in this country with opiates. Louisiana is no exception, as Louisiana, as per 2013, ranked first in opioid prescribing. And this is an absolute epidemic, as you can see in the next slide, all over the country. We've got opioid use is out of control. That's starting to be curbed through regulation, but it's still a massive problem. So for all of you that in this room, if I could ask you the question of if I said, what's your wish list? What's the best case scenario from your perspective of this patient, this worker, this employee that just got injured? What would be some of the things you might say? You might say, well, what if we could get that worker better and back to work without any opiates, and save and in it with a process that saves money for the employer? That sounds pretty dreamy, right? I mean, I'm seeing some heads bob and some just kind of drooling looking at me, so I can't tell. All right, so, but if you had kind of a dream or a wish list, those I would think would be on that list, okay? So improved return to work, no opiates, a healed patient, a satisfied patient, and cost savings. Those all sound really good, right? I don't think anyone would disagree with that. And so that's what I'd like to show you. So we can actually do that, and I'm going to prove it to you in a minute. But some of the techniques that we can do that potentially replace surgery are ligament stabilization procedures, growth factor injections. How many in this room has heard of PRP, platelet-rich plasma? Show of hands. Wow, okay. I guess I'm not advertising enough. I saw about 4 hands. So platelet-rich plasma is a growth factor injection that's called autologous, or from your own body. So does anybody here have a shoulder problem? There's one there. Okay, now we have some hands. So if you go to physical therapy and that physical therapy doesn't work and you still have the shoulder problem and you get an MRI and it says that you have a partially torn rotator cuff, you have, at this point, one of 3 options. 1, you can do nothing about it and suffer until it tears. 2, you can go and get your shoulder scoped and have a minimum 6-week healing process in a cast-looking thing like this, where you have to sleep in a recliner, or you can have regenerative medicine and have none of that. So this is something that affects everyone in the room, either from a clinical perspective for you or someone you know, or from the insurance perspective. So I'm glad I'm here. So growth factors, platelet-rich plasma, you have the healing ability in your body, in your blood. How many people have cut themselves before and it healed by itself? You didn't have to go have surgery for it, right? This pretty much happens every day. Your body wants to heal you and is trying at all times to heal you, okay? You have it within you. What we do is actually just take those pieces of the healing system, whether they're growth factors in your blood or stem cells from your bone marrow, and put those into the area that's damaged, okay? It's an augmented healing process. Okay. You can also get growth factors from amniotic tissues that are not stem cells. They are not stem cells. That would be illegal at this point, but they are growth factors and can help heal it sometimes. Then we have true stem cell therapy. True stem cells come from your bone marrow, okay? Nowhere else. You might have them in fat, you might have them in blood, but we at this time it's not legal to do that as per the FDA. So it's really stem cell therapy comes from your bone marrow and nowhere else. And then we have ultrasound guided nerve hydrodissections and tenotomy procedures. I could talk about that all day, but I'll just say these are the things that we use instead of surgery to heal patients, okay? Here's just a picture. This is kind of, if you're not into ultrasound, you really can't understand what this is, but imagine that you took off your kneecap and looked straight down into your knee. That's what you're looking at. This is a knee that had no meniscus cartilage before and has a bunch of cartilage after. This is just an example of the stem cell procedures we do in knees. Okay, so going back to another case, remember the injured worker. We talked about that injured worker with his back, and now we have an injured worker who has fallen and tweaked his knee. And so the same thing happens in the knee, right? How many people have tweaked their knee before? How many people have had surgery on their knee before? Okay, not too many. It's a healthy group, good. So again, if this patient goes through the conservative treatment plan and is still hurting and is still not able to come to work, what happens? Typically, only one route, and that's surgery. And we already know that surgery is expensive, that surgery is going to take time, that it's going to delay the return to work of that patient if they're ever even able to return to full duty. So I'm here to recommend, or at least introduce you to the concept of interventional orthopedics. So some of you out there are saying, where's the data? This guy's talking, but where's the proof? You have to prove it to us, right? So that's what we did. We partnered with a Fortune 500 company in Iowa called the Meredith Corporation. They're a large publishing company. They actually bought Time magazine this year. They have about 3,900 employees. They are self-insured. We introduced the concept of interventional regenerative orthopedics to their CEO. He loved it. He went in full force and said, let's do a pilot study, and let's see if you guys know what you're talking about, or if this is all just talk. So over the course of 1 year, they had 125 employees that were injured either on the job or off the job. It wasn't all workers' comp. One of them was like a torn ACL. But they had 125 employees that all elected to go the regenerative route instead of the surgical route. And I'd like to show you the data from that year. So there were 9 back pain patients and 53 knee patients. We have a lot more data on shoulders and hips and ankles, but I thought that might be a little bit overwhelming, so I just picked the 2 most common injuries, which is back pain and knee pain. So again, here's that lady, the 35-year-old female who hurts her back, and instead of going to spinal surgery, 9 of the patients elected to avoid surgery and do a regenerative medicine procedure. Now, those procedures were mixed between growth factor injections for some and stem cell injections for others, but the point is that they avoided surgery. They chose to avoid surgery and go this route. And so here's the data. Had these 9 patients chosen the recommended surgical route by the company orthopedic surgeon, this would have been the cost. Now, the company has all the data from historical data, so they knew precisely what their costs would be had they gone that recommended route. And then, so that's in blue, $453,000 and change. And so they went the green route or the regenerative route, and the cost was $46,000. So they saved over 80%, near 90% in cost savings. More importantly, at least to me, you have 9 patients who avoided back surgery that is highly unsuccessful in most cases, and has a proven delayed return to work and opioid usage and even abuse and dependence. So this slide alone I would like to have put on 56 billboards across the country, because this slide alone could change medicine. And I pause for effect because it is that important. Back surgery is a scorn across the country. No offense to any back surgeons in here. There are certainly plenty of reasons to have back surgery. If you have tumors or cancers or paralysis or fractures, there's umpteen reasons to have spinal surgery, that for very good reasons and clinical reasons. But the overwhelming majority of spinal surgery is not done for any of those reasons. It's done because the people are hurting and they can't stand the pain anymore, and they just say, "Cut me, doc." And the outcomes on those instances are pretty bad, and that has been a large contributing factor to this thing called pain management that has now gone out of control. So again, regenerative medicine in these 9 cases really offered a significant cost savings, an avoidance of a major spinal surgery, as well as all 9 patients avoided opiates and returned to work. There's the dream list that we talked about. Check all the boxes, okay? So let's keep moving. What about number 2? I can talk all day, I just start getting hoarse, so let me get a little sip. All right, so case number 2, the tweaked knee. Now, you guys know that 53 out of 53 patients in Louisiana, unless they live in Lafayette and happen to know my name, would be going straight to surgery, right? But fortunately for them and this company in Iowa, all 53 chose initially to try the regenerative route. Again, all 53 avoided surgery, returned to work, didn't use opiates, didn't have a problem with opiates. And on the cost side, the company saved over $1 million, $1.4 million, by avoiding all those surgical costs and the anesthesia costs and the surgery center costs and hospital costs and all the other costs. So given that knee arthroscopy is the most common orthopedic surgery in this country, this slide alone should be on 1,000 billboards across the country, right? So just this one study that we've done with the Meredith Corporation, and the numbers have gotten bigger and bigger because we've been treating them since 2015. I believe this is a very important issue that you guys are going to continue to hear about. It's not going away. It's just too good. It's too good. It's too simple, and it's a huge cost savings. So this just talks about the things that we've been talking about: is expedited return to work, early rehabilitation, and avoidance of opiates, and at least an 80% savings in expenditures to the company. So just in summary, regenerative orthopedics is here to stay, in my opinion, unless something crazy happens and the FDA just shuts it all down. And it can really help people avoid major invasive orthopedic surgeries. and can save at least 80% and create a win-win for both patient and payer and organization. So I'm not, this is I'm done, but I'm not sure if we're taking questions now, if we're going to have a panel.
Now?
Now? Okay, questions? Yes, sir.
When you talk about, stem cells and rejuvenative medicine, is there an age where maybe things don't work as well?
Great question. So the question, just to repeat, was when we're talking about stem cells, is there an age at which we believe that that patient doesn't have enough stem cells in their body? Like, if you see a 90-year-old and this person wants stem cell therapy, you say, well, God, Lee, do you have a single stem cell left? And I've been doing this since 2007, so I'm in my 11th year. And originally, when we started down these tracks, that was kind of the thinking was, well, certainly this poor guy doesn't have any stem cells left, until you look. And what we found has proved, that's the great thing about being involved with a group of doctors who care about this and want to do it the right way, is every single patient we treat, and we've treated over 70,000 patients. 70,000 are all in a registry that we don't control, IRB approved, third party. So we can look at the data, and the data will prove us right or wrong. And so what we found is with increasing age, your stem cell counts don't really drop off that much. I've treated an 87-year-old who just with PRP, with growth factors, he had a fantastic count. So one of the things we do that's very different is I have the only stem cell lab in the state where I can count. I can actually count the cells and know how many cells that I'm giving back. But it's a great question. Also with comorbidities, you'd think, well, if someone's really overweight or if they have other issues, is that something that can affect the stem cell count? What really seems to lower stem cell count is hormonal changes. So in menopause and postmenopause and andropause in men, you can certainly see some decreased counts. Along those lines, people often ask me, other doctors often ask, well, aren't you worried about creating zombies? You're talking about stem cells, and this is going to be like The Walking Dead. No, because we're using your stem cells from your body only. I'm not going to use embryonic stem cells or umbilical stem cells, at least not at this point. Your own body will not reject your own body, okay? And the other thing is our safety data over tens of thousands of patients actually shows that people that receive stem cell therapy have a lower incidence of cancer development than the general population. So is that just an association, or is that actual cause and effect? I'm not going to say I'm not saying that we can cure cancer by giving people stem cells or decrease the incidence, but that's what the data is showing so far. Other questions?
I have another question. It's someone in the back.
I see one right back here. Interesting question. So the question is, how do most insurance companies think about what it is that I do? I presented to Blue Cross Blue Shield back in 2008 or 9, and they said, well, this is interesting, but it's experimental, so we're not going to touch it. Until, I don't even know if I should say this, but I'll go ahead and say it because it doesn't really matter. They're not paying for it anyway, right? So until a very prominent athlete was injured and came to me and wanted it done through insurance, and that athlete was had some relationships with someone with a major healthcare insurance in the state, and then they decided that they were going to pay for it. And so they actually paid for everything I did for about a year. And then they came back and sent me a letter on Christmas Eve, which I was surprised to find that someone was working on Christmas Eve. But it was dated Christmas Eve and said that we're no longer paying you. This is all experimental, and if you say anything, we'll just take all the money back. So I said, well, I guess I won't say anything. But at this time, even though we've done 70,000 procedures and we have plenty of data, it's not level 1 data. So from their perspective, they don't believe that it's real, or that at this point, maybe we have 70,000 is not enough. So at this point, most commercial insurance carriers will say that it's experimental, and therefore they don't cover it.
What about Medicare?
Same, Medicare does not cover it, no. Yes, sir.
Is this be for injury related, or would it also be for scoliosis?
Okay, question was, is this only for injury-related type of pathology, or would it be for congenital things like spina bifida and scoliosis? So what I would say is that at this point in time, there is insufficient data to say anything about spina bifida or scoliosis. Now, I've treated tons of scoliosis patients, but that's strictly for pain control and not in any way believing that that's going to straighten their spine. Again, this is actually a great point. This is a perfect example of where orthopedics is the appropriate channel, or orthopedic surgery is the appropriate channel if you want to straighten a scoliotic spine with Harrington rods. It's well proven, it's been around a very long time, and that's the standard of care. I don't think that a scoliosis patient is going to have their spine straightened at any time with stem cells, but it certainly can help the pain. Other thoughts? Yes, sir. Okay, great question, and thank you. To repeat the question, you hear things on the radio about quote-unquote stem cell procedures and kind of really pushing things out there. And so how is it different, what I do, different from what you're hearing on the radio? Well, what you're hearing on the radio is I'll just call it what it is, it's fraud. So as far as I know, there is no other provider that's doing bone marrow-derived stem cells, that some people are doing fat-derived stem cells, which is illegal as per the FDA, period, end of sentence. So if someone says, I want to do a stem cell procedure on you and I can help you, and they're not going to drill into your iliac crest to get the stem cells, then it's fraud. It's not just illegal, but it's fraud, because there are no stem cells in the substance they're injecting you with. There are no live stem cells in any amniotic product. There are no live stem cells in any umbilical cord product, because to inject something that's allogenic, which means it's not from you, it's from something else. If I want to inject some amniotic product into you, then you probably want that stuff sterilized, right? You don't want to be injecting live amniotic tissue from a birth that just happened into someone. And so the FDA says that all has to be completely sterilized and proven. And the only way you sterilize that is by either microwaving it or irradiating it and killing all the cells. Okay? So what we do is very different. We only do autologous stem cells from that patient only. I think we're about out of time. So one more question.
How long will it be before you all see FDA approval on what you're doing?
Okay, so this is a question that could, so the question was, when do I expect to have FDA approval? Well, we're already FDA approved, because there's really no such thing as FDA approval of a process. The FDA approves either drugs or equipment, components. But what they do not approve processes. So if I'm a knee surgeon and I'm doing knee replacement surgery is not FDA approved. But the components used within that surgery are FDA approved. Okay, so the components that we use in the lab are all FDA approved, but the process of your stem cells being a drug and being called a drug and being approved for a specific indication like knee arthritis, I would love to see that get approved. I just don't see it happening anytime soon. There's a lot of other hands in that pot. So thank you for your questions and thank you for your attention. I really appreciate being here. Thank you.
Next two speakers are going to speak to us on innovative cost comparison tools. First is Donna Smith, who's the Executive Director of Business Development for Fair Health, where she demonstrates how Fair Health data brings value to the various stakeholders with, that cross multiple cost markets in the healthcare ecosystem. She has over 25 years of experience in the healthcare industry, concentrating on benefits, administration, managed care, and provider solutions. Prior to joining Fair Health, Ms. Smith actively served in many facets of the healthcare industry. Along with Ms. Smith, Christine O'Donnell is Executive Director of Customer Experience at Fair Health, again, an independent nonprofit organization bringing transparency to health costs. Ms. O'Donnell is responsible for the overall customer experience for the multiple stakeholder groups in Fair Health. I'd like to welcome both of them. And Donna, I think you're going to start.
Good morning. First of all, thank you so much for having Chris and myself join this panel, because that was very innovative. I like having this type of session because you're always forward-thinking, thinking of so many ways to help the industry. One thing that wasn't in my bio is I actually grew up in Alexandria. So I'm Donna Rose Smith, and I went to Bolton High School and actually went to Louisiana Tech. Moved to Houston with my husband, so I've been back a lot to Baton Rouge. Most recently, we were speaking at the Louisiana Workers' Comp Advisory Council in February, and hoping maybe to engage and work with them in some activity as well. So it's nice to be home. I want to be able to come back more often, so anytime we can supply you with any support, let us know. When we're talking about innovation, we're talking about all the various things in the industry. I mean, we all have an interest, and that's ultimately helping the patient, the consumer, helping that patient get access, getting good quality care, and keeping costs down. Innovation is a word I was mentioning earlier to Marcy. I said, you teed it up for me. We have so many things that we could talk about. But innovation is one of those things that's really overutilized in the terminology, because everyone is innovating. Everyone on a daily basis is really trying to work towards that goal of helping that patient with access and affordable care. So one of the things that Fair Health does, and you've heard it mentioned in the bios, we are a not-for-profit organization that's independent. And what's really important about that is because you can also, oops. This thing is very quick. One of the things that's important is when you're doing your job on a daily basis, no matter what part of the ecosystem you're in, you need data. And a lot of us have data, and a lot of us have more and more data as we continue to grow. But there are so many different parts of the ecosystem that keeps putting pressure points on data. How can you take the data into your daily jobs to help you actually promote your innovation? So Fair Health, our mission is basically to take all of the data assets that we have, to supply it back to everyone in this room if you have need for data, and also being able to support all of the elements of the ecosystem, which I would call the 4 Ps. You have the patient most and foremost, you have the providers, you have the payers, and you have policy. And in all of those Ps, we are supporting all of those in various ways through data. And our mission is about transparency. How can we bring more transparency to these trends? I was leaning over and asking Dr. Bond, are there CPT codes for this right now? Because that's some way that we can go and start looking at the trends. Even though they're not being paid by payers, we can still look at the trends of some of the successes based on a national basis, regional basis, and also, of course, your state basis. Every local population is going to be different, so you want to do some comparative analysis. But that's where independent transparency conversations can take place by using these data points. I think it's also important because when we're talking about consumers, we're all consumers of the healthcare system. How many of you have had surgery over the last 5 years, knowing enough about the industry and realized that, ooh, I didn't know that we were doing this to ourselves? And we're in the industry. How many of you had that aha moment? Okay, a couple of you have. I had elective surgery, and I'm going to just mention this because I went in and did my pre-op and everything, and I asked him, I said, well, can you tell me what my out-of-pocket cost is going to be? That poor young lady, she looked at me like deer in headlights. And I said, well, I just want, no. She said, I think I have your deductible. And I said, that's great, but what's my out-of-pocket cost? And she had no clue. And I asked her, I said, how long have you been in the business? And she said, I've been doing this job for 11 years. I said, has anyone ever asked you what your cost would be? And she said, no, ma'am. She said, we just tell them to sign all these papers, and then we just deal with the payer, the insurance company. And I said, oh, but the consumer, the person sitting there, had no idea what that cost was going to be. No, ma'am. So as a result of that, of course, you end up with balanced billing. You don't know some of the anesthesiologists, some of the contracted providers, whatever it might be. So I had the aha moment, and that's when I started looking at data. And when I was working with Fair Health, I thought, this is going to be great. We can start doing some more analysis of what that would be and how we could help that person that's been there for 11 years do an intake and not knowing how to have that communication with the consumer. So that's just an example. Data in our repository, and the reason I'm going to mention this very quickly is so that we can talk about how data needs to be enough. First of all, you have to have enough of it to where you can be statistically sound, to where you can have enough regional trends to see what's going on in your data. So when we talk about some of the innovative solutions that we have and what we can actually support you with, you'll need to know that we have enough data, not only a national level, but also regional. So looking at our data set right now, we have about 26 billion claim records. Now that's a lot of claims. It trends back to about 2002. We have about 140 million covered lives represented. It includes the 60 million with the dental, but also 493 GeoZips. Now that's equivalent to gypsies. If any of you are familiar with the MSAs and the gypsies on Medicare, that's what we would compare it against. So about 120, 190 at the top end to 493. So this is much more granular. So when we start looking and talking about some of the solutions, you'll see that we have a lot of data that we can actually utilize. This is going to be representative of not only fully insured, it's also going to be self-insured data. So it's going to have all of the different mix of claims so that you can have a good understanding of what's in the local area. We do a lot of data regression testing, a lot of different data validations, and then you can also just do a spotlight on what we have here in Louisiana, which we are growing. We're having more and more data contributors bring their data to us as a part of the ecosystem. It's de-identified. You're not going to know the plan or the health insurance carrier. You're not going to know the TPA. And we de-identified it so it's aggregated for this purpose, mostly for the good of the ecosystem. And when you're looking at the GeoZips here, note that we have 7 different regions within Louisiana versus Medicare. Medicare has 2. That just splits it out. So in other words, if you're really wanting to get into the differentiations between Shreveport, Monroe, Alexandria, Lafayette, you can really get down into that level of detail versus having to stay at the 2 areas, which are the 2 main regions across, I think, right at I-10. And then you look at the CMS. We are also one of those fortunate organizations that we earn the right to take in all of the Medicare data at a claim line level data. A lot of people say, well, we have Medicare data. Yes, you can, and you can get access to it. But we are one of the stewards of data that actually gets down to the demographic information for Donna Smith, understanding all of my claims, and we put it in the repository so that we can also embed it in these type of studies for the good of the consumer and looking at the trend lines. So we're one of the few that gets all 50 states in Part A, B, and D. So what we do with the data, and this is going back to innovation, we try to parse it out into those areas that can be used for multiple reasons. In the past, a lot of people have known our data as being the 80th percentile. The 80th percentile of what? Well, that used to be the UCR, reasonable and customary, and it's still being used that way in many cases for out-of-network claims. However, a lot of people have shifted from the 80th percentile down maybe to 60th percentile, or they're looking at the median or the mean, which would be closer to the 50th percentile, or looking at the allowed data, which would be an aggregated imputed value for more of the closer in-network fees. And then what we do is we put those in benchmarks. And Chris is going to talk about this in a minute about how it has to be statistically created so that it can be robust enough at the granular levels. And also, how do you compare it to Medicare or in-network or other data sources so that you can get some true benchmark of that data trend to understand what's moving. Custom analytics are really important. There's so many companies, and many of you have done it internally. Many of you have licensed third-party organizations to do custom analytics. We've also been asked to do this just based on our data set and even compare against other analytics. A lot of legislative, regulatory analysis, work committees, they use our resources to actually do that so that they can do some comparative analysis, and you'll see an example in a minute. Episodes of care. Many of us know about episodes of care. Many of us know it as bundling. Many of us now have done bundles for 30 years. Some of us did it in the HMO days. Some of us seen, so we've all come around full circle. The part that's really critical here is that we've all evolved and we're all having shifts in how we're working together in the ecosystem. All the provider groups are now looking to how they work together. We were talking earlier about how providers really, you have your NPNs, I mean, you've got your RNs, you've got PAs, everyone's starting to be a part of the mix, but how we're working together with all the behavioral management companies, the psychologists, everyone's now coming together as a group. So we have analytics in that. And then the consumer resources, which we're going to talk about. How do you get the message to the consumer? How do you work with the consumer? How do you work with the providers and the payers to have that conversation with the consumer, and how do we serve them? And then, of course, the record level data. So what I thought we would do is we would dive a little bit into how the benchmark data is created, and then come back to showing you some examples of how those solutions can be used internally.
Thank you. Okay, so now I'm going to talk a little bit more about the nitty-gritty pieces of how the data are used and how they're put together to show you that it is robust and how it might support different kinds of decisions you may be making in your day-to-day operations, or how it can impact your interactions with consumers, patients, and providers. Before we get into that, just talk about some of the common uses of the data. As Donna mentioned, we have different kinds of benchmarks. So we have our charge benchmarks, which reflect the spectrum of provider charges in the markets, in those different 493 markets around the country. And then we have the allowed benchmarks, which are created to reflect the spectrum of in-network prices that have been negotiated by payers with the provider networks. And so this data is often used for developing in-network and out-of-network fee schedules. Sort of the old basic traditional use of this data was that payers would load it into their claims processing systems, and then for out-of-network claims, they would use that to process their out-of-network claims. But what we've seen in the last years is this data is valuable for a lot more different kinds of uses than that sort of old traditional use. And it's a broader use for all the different participants in the healthcare ecosystem. So it's also a resource that providers are using to set their fee schedules and their charge masters, and as a resource for negotiating if they're considering participating with a network on both sides. You can see charges and allowed amounts as a benchmark and decide where you want to be and if you want to participate. A big use of it these days is for dispute resolution, whether it's to support an appeal or whether it's to support higher escalated disputes, and to come to bargaining agreements, or in court, the data can be used to show what is the sort of norm in an area based on percentiles, and we have a lot of information that Donna's going to show you some examples of how that can be used to back it up and to support an appeal. It's used in market research because a lot of information on costs and utilization by market area And although we have those 493 geozips, we can also do custom work so that if you want information as an aggregate for the state of Louisiana, we can do that. Or if you want information for urban areas or rural areas within the state, or you want to look at 3 states or whatever, we can, because we have the granular data, we can recombine it to do what you're looking to do with it. It's also being used a lot now for regulatory rules and some laws. People are looking at our data and actually selecting pieces of our data to use in legislation and regulations. And as Donna's going to show you in a couple of minutes, it's being used a lot for consumer transparency purposes. And the first thing I want to say is that Fair Health does not set UCR. Our data is often used for that purpose, usual and customary rates. We don't make those decisions. As you're going to see, I'll show you the spectrum of data that we make available, and then each organization decides how they want to use it. If they want to use a data point or a set of data points from our data and set that as UCR, that's fine, and that's that particular organization's decision. Or you can use UCR based on formulas that are applied to our data. We don't make any determination about how the data are used. We just want to make sure that you understand what the data are and what they aren't, so that you're making your decisions with a full complement of understanding of what it is. So the UCR determinations are usually defined within insurance policy language, in guidelines from payers. If it's used in regulations, it would usually be defined in there. And any federal agencies may make their own decisions and set different parts as UCR. And so Fair Health offers data in a lot of different formats because there are a lot of different uses for it and a lot of different types of, based on what kind of work you're doing within the healthcare sector, it may be formatted differently for you than for somebody who was doing research. However, the way we divide our benchmarks up into standard products are based on the type of medical information it is. So we have modules for both the charge and allowed benchmarks for professional medical fees, for dental services, anesthesia, healthcare, HCPCS, healthcare common procedure codes, and that's for things like transportation, durable medical equipment supplies. Inpatient facility charges, we offer charge benchmarks for inpatient facility costs, outpatient facility, and also we have a separate area for ambulatory surgery centers if you want to just look at charges in that area. As well as Category 3 codes, which are temporary codes used for emerging technologies, which is one of our newest offerings. And then we also bundle a lot of the benchmarks together to create episodes of care, which is really the end-to-end look at a treatment path from beginning to end, and we offer that as well. So there's a lot of different types of information that are available. And then just to give another look at the GeoZips, how we develop our data and our benchmarks are based on a procedure code and a geographic area. As Donna said, there's 493 GeoZips across the country. There's about 112 gypsies right now in Medicare. And some of the GeoZips incorporate different areas, multiple 3-digit zip codes, but that's how they're usually defined, by the first 3 digits of a zip code. And again, they can be rolled up, they can be mixed and matched, and provide custom data. And this is just to give you a feel for what the data really are. We array them by percentiles, and that a percentile is a statistical term which really talks about where a value falls in a spectrum of values. So basically what we do is we take the data that we've collected for a specific procedure code in a specific geographic area, we array it from lowest to highest, and we assign it to percentiles. When there are not enough data, there's 10,000 procedure codes. Not every one of them is done very often. In fact, most of them are not all that common, especially in certain areas. So we have very robust statistical methodologies that we use to develop the benchmarks for those types of charges, so that even if you're dealing with a rare procedure, in most cases we can help develop a value for that and a range of values at all the different percentile levels based on accepted statistical methodologies. And there you see just an example of showing from the 50th to the 95th percentiles, but also the mean or average value, the median, which is the 50th percentile, and the mode, which is the most commonly occurring value in that set for that procedure code in that geographic area. And then just to give you another comparison to CMS, and Fair Health data against Medicare data. Our data are based on the 493 regions, and then we're very able to mix and match and do custom regions for you, whereas Medicare has 112 gypsies right now. And then our methodology is really based on what's happening in the market. Donna showed you we're getting this data in from all over the country, and they're very recent costs for recent procedures. And so we're really reflecting what's happening in the private insurance market with our benchmarks. On the other side, Medicare is developing relative values and conversion factors in some somewhat secret committees. And then they will adjust those based on the geographic area, so they'll usually have adjustment factors based on the geographic area. And then some procedures are not covered or not included in the Medicare fee schedules because the Medicare population is very specific for the elderly, disabled, and the end-stage renal patients. So that's a very specific population, whereas the private insurance population is typically younger and may be more healthy, and so there may be different things. And then again, Medicare rates are set with budgetary reasons in mind. They have to keep to set budget. They may have preferences for providing incentives for certain types of procedures over others that they will reflect in their rates that they set. And then they may not have the data for things that are not often experienced by Medicare patients. And on the other side, what you're really seeing with the Fair Health data is a mirror of the private insurance market. And here's just an example. Donna was talking about how the 80th percentile sort of used to be the rule in private health insurance, and that was where very many payers would set their usual and customary rates. And what we're seeing here is the comparison of an 80th percentile charge to an average charge to the 80th percentile allowed charge to the average allowed charge to the CMS rate. So see, there's a whole spectrum of values out there. And in your work, you can figure out where you want to be or how you want to set your data. And there's a lot of different data points within that range that you can use to select it. And I'm going to turn it back to Donna for a minute. And
So I'm going to just say, I did pass stats class. For those of you that did take a stats class, that was pretty up your alley. But anyway, it's a methodology that's really important. I think the key word here is that it's market representative. I think the key, going back to bringing everyone to the same sandbox to have a conversation about what values to use, is commonplace. When Marcy was talking earlier about all the legislative movement on the balanced billing issues. We have been brought in by a number of states, I think 24 states, and actually we are working with Senator Cassidy's group and multiple other senators, and actually Seema Verma. We've been at many of the roundtables. They've invited our president, Robin Gelbert, to be participating in these think tanks, mainly because of looking at our data. Whether it's the 80th percentile, whether it's the 50th percentile, or whether it's 125% of our allowed, or whatever it might be, we have different solutions that we can package to support some of those conversations and those evaluations. I think it's key for all of us to understand that there's a lot of different ways to go, and I understand that there's a lot of push and pull based on the provider provider and the payer side, but how can we come together to use something that we all agree on? And that's where, and being an agnostic data set, not one or the other that's so influential. So that's where we've been coming in to have those discussions and support that. And even when you're looking at innovative ideas, as Dr. Bond's, area, how do we prepare for that, or how he can look ahead to say, here's the cost, and support those costs and innovation to help bridge and bring in more of the growth, because that's where you want innovation. You want to look at market segments, but you have to have a little proof, that some of the savings. So that's really our objective. The other part, of course, is consumer platform. I am just scrolling through these screens just so that you can see. We do have a website out there that we have published that's really for personal use, not for business. And the reason I say that is we had a phone call the other day in our customer service. A law firm called and said, I got locked out of your consumer website. And one of the disclaimers that comes up is saying it needs to be for personal use, not for business. And he was using it for a dispute. And he wanted to have that. And I'm like, you're a lawyer. That's not even right. But anyway, this is a website. Please go and look, because we do private label this. We will actually provide these to not only the payers and third-party administrators and employers. The states have now linked to this because they want it for their transparency conversations to help consumers just become more aware. But it does show in and out of network type of estimates. Keep in mind, it's just estimates. It's not going to have their plan design. It's not going to have their accumulators in it, but it is going to give you estimates. And it just gives a little bit more education. We do have the videos, so if you're diabetic, you can go click on it. We also have providers that are now asking if they could use this in their waiting room, put it on their computer so they can have that as another link to help educate on what cost might be. So we private label that. We have a lot of literature, and we have the provider tools that also are eligible for the providers so that they can do some modeling against what the Medicare and where they should be, but also to see the trends so that it's not meeting one of those outliers, because we do a lot of statistical outlier methodology to make sure that any billable rates are not being, pushing everything up. So that's another area. But patient materials are really very important. And how do we get that data to everyone, especially when you're talking about balanced billing and we're talking about high deductible health plans? How do we help educate these? I've been in this industry, I know it said 25 years, but I'm going to say 31 years. So 31 years I have been in this business, and we have always been talking about how we can educate the members. How can we talk about getting those members to understand what they're buying, what they're doing, which place, do they go to an ASC, do they go outpatient? We've been talking about this for so many years, and we're all trying different innovations to try to get the person engaged. And whether it's at the point of the provider, like when I went in for my pre-op, or at the point of the payer, case manager saying, hey, let's walk you through this, or whether it's a legislative regulatory requirement. All of these are going to have to work somehow because we have to have some education on what the costs are. And I think that's where we're here to support. I already talked about how we're talking with CDC. We did a GAO study for air ambulance. They wanted to see what the rates were. You probably saw that being published. We also did we've done, again, many balanced billing hearings, not only in DC, but also at the local levels. A lot of states have brought us in with their work groups to have some variations to see where they might land, and trying to bring everyone together on some point of reference that can be used. Connecticut's an example where they're using our 80th percentile in their balance billing. You have Pennsylvania that's using the 85th, which I think they might go down a little bit. But and then, of course, we have the GAO study for air ambulance. I'm going to just mention we have all of these items that I'm scrolling here on our website. Feel free to go look, because this also addresses the opioid. We've done now 6 studies just looking at the diagnosis. It's after the fact. I mean, once they're addicted, what happens on all those diagnoses? What's happening with their services that are being rendered, and looking at the cost in various regions. And Louisiana's mentioned. I think you'll see it in there. But we also have many of these pie charts that you'll be able to see some of those based on the trends and the data. Not surprising, a lot of these are probably consistent with what you see in your own practices or your own data sets, but it's really more of a supporting role. We also have a lot of various, like we did concussion one year. We're doing now one with Lyme disease that we did recently. There's another one on telehealth. I mean, there's a lot of different trend lines that you can look at to see what's happening in certain regions and populations. But again, we're adding more data, so if you are a payer out there, insurance payer or a third-party administrator payer, and you're not contributing and being a part of this, we welcome you to be a part of it. It's growing, and we want to continue having that. It is de-identified, so we're not going to tell you who, but we welcome that. I'm going to leave enough questions, time for questions, if that's all right. Okay. Sure.
Yeah, as we talk about transparency in healthcare and cost transparency, I mean, our system is such a complex, convoluted system, and that starts with government pay. And I can remember as a child when everything was just 80-20.
Yep.
And then Medicare came in, and we started getting paid based on percentage of charges. And if you kept your Medicare fees low, it was disadvantageous.
Yep.
You had to keep going up. So do you ever see the government changing how they are involved in payment? And I think that change would certainly help the complexity across the board and how, you know, we can be transparent in healthcare costs.
Okay, I'm not sure if everyone can hear that question, but I'm just going to summarize it. Whether we see any movement with CMS adopting any of their modeling for their annual review for budgeting on the Medicare rates and how it's going to be, yeah, and this is, you know, Fair Health is agnostic. We are really independent, so I'm just going to say, don't know. But I do know that Robin Gilbert, our president, has been speaking with CMS. We've actually spoken with them many times. The RUC committee, which most of you know, they're the ones that are making those decisions. And those are the ones that are going to be influential, and whether or not that can be carved out of the decision-making on a budgetary perspective, I think is the key. But they are in discussions right now of looking at commercial market data and looking at that as benchmarking. So that is something they're going to be looking at our data to see how they can support benchmarking. I don't know that they'll totally remove it, but they'll use it in benchmarking to at least see where they are on the highs and lows. Yes?
Is medical tourism enough big enough factors where it would influence any of the studies? If people literally leave the country to go get this somewhere else?
I'm not sure I heard all of that. But oh, medical tourism. Thank you. Yes. So we do have some stats on medical tourism. We do have some that's actually domestic tourism as well, on the coding and how we've done some of the analysis. And we can do it based on region, so be happy to share more with you. Mm-hmm. We do this. We have clients calling us just like that. I mean, they'll call and say, hey, do you have enough data to where you can show us a trend line in this particular region? Oh, okay.
The mics.
You're being instructed to use the mics, which are on both sides if you'd like to come up. Mainly because I have poor ears. I've been to too many concerts. There's a diagnosis for that, I know.
Thank you. You mentioned air ambulance a little while ago, and you said that you serve as like an arbiter or something in hearings about that. Can you go into a little bit of more depth about how that works for an individual that's got a $40,000 air ambulance bill that the insurance isn't paying, but $2,000 of?
We've already moved on to the next session, but there is a slide at the very end that I didn't mention, and it's called a histogram. It actually shows the billable charge in relation to that particular area for all the other providers and how it fits into the scheme of the statistical model. And you can see if there's a red dot, you'll go back and see it, but they're on the red dot if that billable charge is way in the extreme, and everyone else in the median and mode is in the middle here. Let's just say it's $500 versus $50,000. And you can look at it regionally, you can look at it state, and you can look at it nationally, and you can see how that goes. We don't necessarily, from Fair Health, go into arbitration. We just serve the documents and the supporting evidence for you to go in.
I just
and talk
want to
about
say
that.
one thing, too. We've had consumers calling about that and using our data to go back and present what they see on our website versus what they've been billed. And they've called us back in tears telling us how much money that they saved because the provider was willing to negotiate with them at that point.
Exactly. Yeah. And we also have, I mentioned the General Accounting Office, the GAO. They also used our data in their study to see how and if any areas were egregious. And the results are on our website. I think you can go in and look at that. But that's, again, a part of how we can help the ultimate, patient and the consumer. There's a question. You want to go ahead, Chris?
Sure. There's actually two websites. So the consumer website, where you can go up and look up charges for personal use, is fairhealthconsumer.org. But the other website, fairhealth.org, is where all of the business resources are and the samples of the white papers and the opioid research and all of that, and a description of all the different services that we have available.
Just remember, we really are trying to stay as independent as we can to serve all sides of the conversation, because that's really important. I mean, that's important to the consumer, which is the patient ultimately. So,
Another question.
yeah.
The proposed Fed changes for January that now pay for a blended E&M code. Do you have any thoughts, and we have real concerns, those of us in primary care, about what that may do to treatment of chronic disease and quality of care?
I'll let Chris.
There are some pretty big changes considered there. Right now, what we see on that is there have been thousands of responses to CMS on that. I really doubt that it's going to be implemented this year, but they're going to be thinking about this long term, and we need to start thinking about other ways to look at this, because they're looking at blending the E&M charges for office visits, and that's going to have a huge impact on everybody.
And someone asked us not long ago, they said, do you think it's going to be equivalent to the ICD-9 to ICD-10 change? And in some areas, it could be, because of just the claim systems and looking at how you currently pay and how you currently bill. And there's a lot of downside. Any other questions? Well, we really appreciate you having us. We could have gone on for at least 5 hours. I mean, we have slide decks after slide decks. But thank you so much for having us. We have more. We'd love to have conversations with you. So we have business cards up here if you want any more information. Thank you again.